have fun assessing yourself. And we have MCQs from the beginner level to the expert level. So these comprise of standard multiple choice questions, which are commonly asked in all the university exams of all the states. So we have subscription plans. We offer basic, standard, and mentorship program. So mentorship program is a wholesome program, which we offer at a special rate of 50,000. And you can also use the code Dr. Divya 20 for discount on the subscription. So here we, in addition to the pre-recorded classes, live class, live doubt clarification, as well as quick revision, examination module, we also give you one-to-one personalized guidance as well as notes. You can book a slot for personalized counseling session, and you can use the code for the first free live class. And about this internal exam marathon classes, which we have started since April 22nd, it's a duration of about 45 days. Here we are offering you rapid revision of all the important questions, quick revision of volatile facts, as well as we are also covering the multiple choice questions there and there where regarding the topics. And this is beneficial for everyone from the all university exam. So all of them have been compiled and we offer you here. So you can use the code Dr. Divya 20 for the first free live class as well. So we shall begin with today's class, Abdomen and Pelvis, Series 5. So here, today we will be dealing with questions on urinary bladder, male urethra, uterus. Then also short answers were descent of testis, tracheoesophageal fistula, rotation of the midgut, and development of pancreas. So first coming to the essay questions. First question is urinary bladder. So this question, we need to answer what is urinary bladder, the definition, the location, presenting parts, features, relations, a little bit about its development, nerve supply, and applied aspects. So when we define urinary bladder, so what is urinary bladder? So urinary bladder is a hollow viscous, okay? It is a hollow viscous, a muscular structure it is, which acts as a reservoir of urine. So the position of this, that is the location or the position of the urinary bladder, it varies with the, when it is filled and when it is voided or when it is empty. So with the amount of urine with the bladder, the position also changes. So in children, the abdomen, the bladder is abdominopelvic. That is, it occupies both abdomen as well as pelvis. Because the pelvic cavity in children is small and the bladder neck will be at the level of the upper border of symphysis pubis. So this here will be the symphysis pubis. So bladder neck will be little above here. In adults, it is in the pelvic, in the pelvis when it is empty. Whereas when it is filled, it just comes above the plane of the lower border of the symphysis pubis. So this, when it is distended, what happens is it becomes an abdominopelvic, and from the lesser pelvis, it comes to the peritoneal region. So this shape of this urinary bladder, when we see, it is tetrahedral in shape. So it is it is tetrahedral when it is empty. And when it is filled, it becomes ovoid in shape. So the capacity of this urinary bladder, how much of urine it can fill, okay? So it is about 120 to 130 ml, and the mean capacity is about 220 ml, okay? Beyond that, a sense of filling and urge to micturition develops, okay? So the desire to micturate develops when the bladder is filled to about 150 to 250 ml. So when we say the physiological capacity or physiological capacity of distension of the bladder is you can hold the urine without any undue discomfort. Okay, so painful, that is between 250 to 450 ml. Painful sensation starts when it is above 450 ml, and anatomical capacity means the volume of the urine just before the rupture of the bladder, means that is the anatomical capacity. So that is about 1 liter. So when we see the presenting parts in an empty bladder, that is, it is tetrahedral in shape. So it will have an apex, it will have a base, okay? This is the superior surface and 2 inferior lateral surfaces. And 4 borders. So it will have an anterior border, posterior border, okay, and 2 lateral borders, and there will be a neck. Okay, this is a 2 dimension, so you may not be able to see, make out the borders properly, but this is anterior, lateral, posterior border here, okay, and the neck. So apex, if you see here, it is directed forwards and to the apex. So the apex gives attachment to the medial umbilical ligament. So this is the medial umbilical ligament, which will extend up to the umbilicus where in the anterior peritoneal wall, when you see. The base here, the base is the posterior inferior surface of the bladder. So this will be directed backwards, okay? Backwards and downwards. Yes. Then the superior surface here, this is the superior surface. Superior surface is mainly triangular. Okay, if you see it's triangular and it is actually covered by the, so here if you see, this will be the superior surface. This will be the base of the bladder. This is the apex of the bladder. So superior surface is covered by the peritoneum. Okay, and then the borders, here we have anterior border. So anterior border will extend from the apex to the neck of the bladder. Okay, and it will separate the 2 inferolateral surfaces from each other. Posterior border separates the superior surface from the base. Okay, this is the posterior border. It will separate. And lateral borders, each border separates the superior surface from the inferolateral surface. Okay, so this is, that is, it will extend from the entrance of where the ureter enters from this point up to the apex. That is the lateral border. So neck of the bladder. So anatomically, so we have what we call it as the anatomical neck and the physiological neck. So anatomically, the neck of the bladder is defined as the lowest point from the urethra. So from where the urethra begins. So lowest point from where the urethra begins is the anatomical neck. So that is situated about 3 to 4 centimeters. Okay, so this is the lower border of symphysis. So symphysis pubis. So about 3 to 4 centimeters behind that comes the neck of the bladder. That is the anatomical neck. So in males, it is surrounded by the prostate gland. So you can see the prostate gland here where it surrounds. And in females, it lies at a lower level and comes in contact with the this thing. What is that? The urogenital diaphragm. Physiologically, the bladder neck includes, in females, it includes the entire female urethra, and in males, it is the prostatic urethra, okay, which is called as the physiological neck. Okay, so why we call that as physiological neck is because the detrusor muscle is the muscle which is present in the bladder. It will extend up to that, okay. In the female, it will extend the entire length of the urethra, and in males, it will extend up to the prostatic urethra. So because of that, we call them as the physiological neck. So in females, we also see the 2 ligaments of the urinary bladder. Okay, so in the females. So here we have, that is the lateral ligaments, 2 lateral ligaments, and the lateral puboprostatic ligaments. Okay, that will be in male. Puboprostatic ligaments we'll see in the male. Okay, and lateral and medial near the pubic symphysis. This is anterior, this is posterior. Okay, and here we see this posterior, a pair of posterior ligaments. Okay, so basically in the true ligaments, when we say in both males and females, we have the median umbilical ligament. Okay, median umbilical ligament, which will extend from the apex to the apex of the bladder to the umbilicus. Okay, so basically it is the remnant of the urachus. And for puboprostatic. So puboprostatic, that is a pair of lateral and a pair of medial. So that we see it in the males, puboprostatic. In the females, what we see is the pubovesical. Okay, so we call them as the pubovesical ligaments. And a pair of lateral ligaments. Okay, so this is a pair of lateral ligaments. Pair of lateral ligaments we see. And a pair of posterior ligaments. So these are the ligaments which we see in both male and female. Only here, male puboprostatic, in females we say it as pubovesical. And false ligaments are basically the peritoneal folds. Okay, so they are about 7 in number. 3 anteriorly we have 3. That is this was median umbilical fold. There we call it as the medial and the lateral umbilical folds. A pair of medial umbilical fold and the lateral umbilical fold will be there. Okay. And a pair of lateral false ligaments, which will be extending from the bladder to the lateral pelvic wall, that is also formed by the fold of the peritoneum. And posteriorly, there will be a pair of sacrogenital folds. So they are basically the peritoneal folds which form the false ligaments. So relations, when we come to the relations, the base of the bladder behind, it is related to, that is between the bladder and that is the behind the base of the bladder, there is the rectum in males, whereas in females, uterus will be there. So here we get the rectovesical pouch in males, as whereas the vesicouterine pouch in females. Okay, so in addition to that, there will be vas deferens as well as the seminal vesicles in males, okay, which is separated from the rectum by fascia of Dinovidus. So that is seen in the near the base. The superior surface. So superior surface here above, it is covered by the peritoneum. And so there, the loops of the ileum, they come in contact there, okay, as well as sigmoid colon and uterine. In females, the uterine cervix comes in relation to the superior surface. Then the anterior surface of the bladder here, okay, there will be a space which is known as the retropubic space. Okay, I'll tell about it later. So puboprostatic, and in addition to that, puboprostatic ligament in males and pubovesical ligaments in females will be there. Okay, and obturator internus and levator ani muscle you may see in the inferolateral surface. Apex, it is related to the median umbilical ligament, and here neck part, it is related to prostate gland in males, whereas in the females, it will be related to here. It will be directly in relation. This is the urogenital diaphragm here. So it will be related to the urogenital diaphragm. So these are the relations which the base which we see. Okay, so this is the ampulla of vas deferens. So vas deferens, it forms the ampulla, then seminal vesicles. Both the ducts join together to form the ejaculatory duct. Okay, and it opens into the prostatic utricle. So here inferolaterally, so this is the bladder, this dotted line, this is the prostate gland. So here you can see the levator ani muscle, and this is the ischial part. So here you will have the obturator foramen where you can see the obturator muscle also. So this space here, this is the retropubic space, which I told you earlier, that is the retropubic space of Retzius. Okay, so this space is very important, space of Retzius. So if you see here, it is a horseshoe-shaped kind of potential space here, which intervenes between the anterolateral pelvic wall. So this is the anterolateral walls, right? So this is the, between this anterolateral wall and the sides of the bladder, okay, we have this space. So this space, why is it important is, it will act like a bursa to allow for the distension of the bladder. Okay, so the space acts like a bursa. So if you see the boundaries, so this space of Retzius can be asked as a 3-mark question, or it can be asked as an MCQ question. Okay, so borders of this, the boundaries of this space is in front, there is symphysis pubis, if you see here, and the body of the pubis. Okay, this is symphysis pubis and the body of the pubis. And behind and on each side will be the posterior true ligaments. Okay, so this side here it's not seen, but we will have the posterior true ligaments. And above will be the peritoneum. Below will be the puboprostatic or pubovesical, okay, ligaments, this one. And medially will be the inferolateral surfaces of the bladder and the prostate. Whereas laterally will be the fascia covering the levator ani muscle. So this space, it contains the retropubic fat and the vesical plexus of veins. Okay, so vesical plexus of vein as well as the retropubic fat. So why this is clinically or surgically important is, so surgical operations of the bladder and the prostate are approached retroperitoneally through this space. Okay, retroperitoneally, or that means from behind the peritoneum, through this space we approach the bladder or the prostate. Okay. And yeah, so that is about the retropubic space. Then coming to the interior of the bladder. Okay, so interior of the bladder, when we see, what are the structures we see? So here, the interior of the bladder will show number of mucosal folds. Okay, so there will be a lot of mucosal folds there, which we call it as the rugae. So they are present in the entire bladder wall except near the trigonum. Okay, trigonum vesicae. Okay, trigonum vesicae, or otherwise called as the internal trigon. So these folds, they are present when the bladder is in a resting state or in a undescended state. But when it is distended, it disappears. When the bladder stretches because of when the urine is filled, it disappears. Otherwise, we see the folds. Next, coming to this internal trigone, so if you see here, it is a triangular, it's like an equilateral triangle here on the inner aspect near the base of the bladder. So here the mucous membrane is very tense and glistening because there is absence of the submucosal port here, submucosal layer. Like histologically, when we talk about mucosa, submucosa, that layer is absent here. So that is why it is very tense and glistening. So the boundaries of this trigone, so apex here, it is directed downwards and forwards, and it is formed by the internal urethral orifice, guarded by the internal urethral sphincter here. Okay, so that is the apex. So in the males, what happens? There will be a rounded elevation known as the uvula vesicae. Okay, so this is the rounded elevation known as the uvula vesicae, which projects upwards behind the urethral orifice. Okay, so and this uvula vesicae is formed by the median lobe of the prostate. The uvula lies within the what we call it as the sphincter vesicae. Okay, then comes the base. So the base is formed by, here if you see, this is the base. So this base is formed by the interureteric ridge. Okay, this is the interureteric ridge here. So this interureteric ridge, otherwise called as the bar of Mercier or Mercier's bar. This extends between the orifices of the two ureters. So the ureters are opening here. You can see this is the ureter orifice. So between these two ureteric orifice, this interureteric ridge extends. So this is that each posterolateral angle of this trigone presents. So at this posterolateral angle, if you see, it will have a ureteric orifice here. Okay, so on the sides here, we will have from the what is that, ureter to the urethra, okay, which is called as the uretro-urethral ridge, okay, or otherwise called as the Bell's bar. So that is a fold which extends here. It forms a ridge here. Okay, so those are the things which we see. What is the importance of the trigone is, it is the most fixed part of the bladder, okay, and it is the dependent part also of the bladder, and it has a rich supply of blood vessels and nerves. Okay, it is developed from the mesoderm by the incorporation of the caudal parts of, that is the two mesonephric ducts will unite together. Okay, they fuse together to form the trigone of the bladder. So trigone of the bladder as such is a short essay question or a short answer question. So you need to know about it. The blood supply of the bladder is basically by the superior vesical artery, inferior vesical artery. In addition to that, the obturator artery branch from the inferior gluteal artery, and in females, you also the uterine artery supply. So basically, it is the superior vesicle and the inferior vesicle. Okay, the nerve supply, basically they form the vesical plexus, okay, which we saw, which is situated in the space of Retzius. Nerve supply. Now, the nerve supply of the bladder is very important. It is supplied by both sympathetic as well as the parasympathetic. Okay, sympathetic and parasympathetic divisions of the autonomic nervous system. So, sympathetic supply. So, the preganglionic fibers, they begin from, here if you see the preganglionic fibers, they arise from the lateral horns of T11 to L2. Okay, segment of the T11 to L2 segment of the spinal cord. And they relay in the hypogastric plexus, which is situated in the just in front of the sacral promontory. So the postganglionic motor fibers, which arise from the plexus, okay, arise from the plexus, they will form the right and left hypogastric nerves. And these hypogastric nerves, they will descend behind that is by the side of the rectum, and they pass forward, okay, where they reach the body and the neck of so this is the body as well as the neck of the bladder, okay. So this hypogastric plexus is situated in the sacral promontory. From there they begin, okay. That is the postganglionic fibers, they begin, and they reach the bladder by forming this, that is the right and left hypogastric nerves, and they reach the bladder's body as well as the neck. Okay, so usually the sympathetic stimulation, okay, it will stimulate the sphincter vesicae, okay, it will stimulate. So if you see here, this is minus, this is plus, means it will stimulate the sphincter vesicae here, okay, whereas it will inhibit the detrusor muscle. So it will act as a nerve of filling the bladder, okay. So because the sphincters are stimulated, what happens? Sphincter becomes tight, whereas the muscle is, it will inhibit the muscle. So muscle is not contracting, right? So muscle is relaxed. So the bladder fills, okay. So it is known as the nerve of filling, okay. It acts as nerve of filling, okay. Then parasympathetic. So the parasympathetic, if you see here, the preganglionic fibers, they arise from the lateral horn of S2, S3, S4. Okay. So they are coming from there, and they form the pelvic splanchnic nerves. Okay. They form the pelvic splanchnic nerves, or otherwise also called as nervi erigentis. Nervi erigentis. So these will go forward by the side of the rectum, or same way like how these follow. Okay. And the neck of the bladder, and they reach the body and the neck of the bladder. So the cell bodies of these postganglionic, usually the postganglionic fibers of the parasympathetic, they lie closer, they are shorter, right? Okay. So they are situated close to or within the bladder wall. Okay, they are present there. So this parasympathetic is the motor supply for the bladder, and it acts. So what happens is, on stimulation, if you see here, it will stimulate the detrusor muscle, whereas it will inhibit the internal urethral sphincter. Okay. So this is the thing. And you have to also know that the external urethral sphincter is supplied by the somatic nerve. Okay. Somatic nerve is the muscle supply, that is the supplying the skeletal muscle. So here it is the pudendal nerve. Okay, so this pudendal nerve supplies, whereas these belong to the autonomic nervous system. Okay, this belongs to the somatic nervous system. Right. So when we see the development of the bladder, so this is the hindgut portion. Okay, hindgut will be divided. Okay, with the developing septum, it will be divided into a primitive. This is the urogenital sinus, and it will be this portion forms the primitive rectum. So from the primitive rectum, the rectal portion as well as the upper part of the anal canal is formed. But whereas from the urogenital sinus, this urogenital sinus, what happens is, the upper part of it is distended, okay, it dilates, and lower part is little narrower. Okay, so this part we call it as the upper part, we call it as the vesico-urethral part, and the lower part we call it as the pelvic part of urogenital sinus. So from this vesico-urethral part of this primitive urogenital sinus, it forms the bladder, as well as the apex of the bladder, because here we will have the allantois, okay, near the hindgut. This is the umbilic. This allantois also contributes to the formation of the apex of the bladder. So once the bladder is formed, the allantois gets obliterated, and it will continue, that it remains as urachus. Okay, and later we call it as the median umbilical ligament. Okay, right. Whereas that is the that is major portion of the bladder wall, the neck, all those things. Okay, but whereas the trigone of the bladder, so trigone of the bladder, if you see here, what happens? This mesonephric duct will be opening there. So on either side, two mesonephric ducts will come and open on either side. Okay, so from the mesonephric duct only, we will have the beginning of the ureteric bud, okay, which will be forming the urethra, right? So once these mesonephric bud, which comes in relation to the developing bladder, what happens is both of them, they will fuse. Okay, and they will form the trigone of the bladder. So that is about the development of the urinary bladder. So developmental anomalies include like rectovesical. Okay, so there will be a communication because here, if these do not separate, okay, the rectum portion and the vesical portion, if they do not separate properly by the formation of the septum, what will happen is it will result in the fistula. So rectovesical fistula. So urine may come, this will go to the rectum and then come out, or vesico-vaginal fistula. So here the bladder will communicate with the vagina in the females. So rectovesical, we see it in the males. Vesico-vaginal, we see it in the females. Then this is the urinary bladder. So this is the allantois. Okay, so if the allantois doesn't get obliterated, it may form what we call it as the fistula. And the urine may extravasate here through the umbilicus. Okay, so that is urachal fistula, we say. The other one is the urachal cyst. So here what happens, the proximal and the distal portion, okay, proximal distal portion, they get obliterated, but in between it may remain patent, forms a cyst. Then the proximal part here near the apex, it will be obliterated, but here the distal part towards the umbilicus will remain patent. Okay, since it forms a blind end here, it forms what we call it as the urachal sinus. So these are the three developmental anomalies we see. Then other thing is ectopia vesica. Ectopia vesica here what happens is this urethral orifices. Okay, instead they will be like ectopic. So ectopic vesica. So it is in a abnormal site. Okay, where this ureteric orifices. So instead of opening, that is into the bladder, okay, they will open. So usually they open at the posterior lateral angles, isn't it? So posterior lateral angle, it will open, but instead they may open into the mucosa of the bladder wall. Next is ectopia vesica. This is the condition here. So what has happened is the entire bladder is exposed outside. Okay, so the wall is not formed, and you can see it is exposed towards the outside. So these are the things which we need to know about the okay. So bladder. So most important things which you have to remember about the bladder is urinary bladder, commonly asked. Okay, its presenting parts. So you should know what are its presenting parts and the relations, parts and relations, which is very important that you know. You have to know about the space of Retzius. So what is this space and what is its clinical importance? You need to know about the nerve supply as well as the development part. So development, basically the source, which are the two structures which are forming the bladder. That is what contributes to the formation of trigone and what contributes to the formation of the remaining portion or the majority of portion of the bladder. Okay, so these are the things which you need to know. So next we study about the urethra, male urethra. Male urethra is very important. Okay, so male urethra, what is male urethra now? So, okay, so it is the common tubular passage. Okay, it's a common tubular passage which is for the elimination of both urine as well as semen. So if you see, it extends from the external urethral orifice, okay, extends from the external urethral orifice at the apex of the trigone, sorry, extends from the internal urethral orifice, that is at the, which extends from the apex of the trigone of the bladder up to the external urethral orifice, close to the tip of the glans penis, okay. Excuse me. So this urethra, okay, we have to know the parts, the features, blood supply, nerve supply, lymphatic drainage. So we will see into it. So this male urethra, we divide it into 4 parts. That is the prostatic part, Okay, the small portion, we call it as the pre-prostatic part, the prostatic part, the membranous part, and the spongy part. Okay, so these are the parts. So the total length of this male urethra, it is about 18 to 20 centimeters. The pre-prostatic part here is very small. It is about 1.5 centimeters. The prostatic part measures about 3 centimeters. Okay, so this is in a sagittal section. This is in a coronal section, what we are seeing here. And membranous part here, okay, it is little different, the anterior wall and the posterior wall. So anterior wall is about 2 centimeters, posterior wall is about 1.25 centimeters. Then the spongy part is about 15 centimeters. The average breadth of this, so the length of this and the length of the different parts is very important. So average breadth of it will measure about 6 millimeters, okay. So here, when we take a cross section, okay, here you can see, when we take a cross section of this different parts of the urethra, male urethra, we see different shape. So if you see near the pre-prostatic part, it will be, that is the stellate shape. The prostatic part of the urethra, it is like a crescent. Okay, convexity to the front, like a horseshoe shape, you can see here. Then the membranous part is again star-shaped or stellate shape. Then in the spongy part, okay, spongy part will differ at different places. So at the bulb of the penis, okay, here it is trapezoid. Near the bulb, it is trapezoid. Then the body of the penis, it will show a transverse slit-like or horizontal. At the base of the glans penis, it will be inverted T-shaped. Okay, here it will be inverted T-shaped. And at the external orifice, it will show a sagittal or a vertical slit. Okay, so here it will be horizontal. So these are the different, that is shape of the lumen in a cross section. Okay, so here, once you know the parts, you should also know the prostatic urethra, okay, which we call it as it is very important. This as such can be asked as a 3-mark question, or the features like an MCQ question. All are the features except like that, or what these are structures opening in the prostatic utricle. So except or something like that will be asked as an MCQ question. So here what we see is first is the urethral crest. Okay, the prostatic part, we see the urethral crest. So this urethral crest is what? It is a median longitudinal mucous fold. Okay, so as it gradually increases in height as it descends, and it reaches maximum of about 3 millimeters in the middle of the crest. Okay, so here it becomes about 3 millimeters, and again it fades away down. Okay, so this crest, how it is produced, this urethral crest is basically, it is produced by the insertion of the trigonal muscles. The trigonal muscle, when it gets inserted there, okay, trigonal muscle of the ureters, when it gets inserted, it forms this crest. Then we see the colliculus seminalis. Okay, so this is otherwise called as verumontanum. So this is the rounded elevation we see in the middle of the crest. So this will show 3 orifices. Okay, so one is the prostatic utricle in the middle. Okay, this is the prostatic utricle in the middle, and ejaculatory duct on either side. Now, this prostatic utricle, it is a cul-de-sac. It means it is about a mucous cul-de-sac. When we say cul-de-sac, one end will be the blind end there. So it measures about 6 millimeters long, and it will extend upwards and backwards from this colliculus, okay, to behind the median lobe of the prostate. So the colliculus basically developmentally it corresponds with the Mullerian eminence. Then we have ejaculatory duct. So ejaculatory duct is about 2 millimeters long, and it is formed by the union of the vas deferens and seminal vesicles. Then we have small openings all around here, that is prostatic sinuses. They are these, so this entire thing is the prostatic sinuses, where you see many openings of the ducts of the prostate gland. Okay, so these are the things which we see within the prostatic features of the prostatic urethra. So this is very commonly asked as a 3 marks question. So coming to the other parts of the male urethra, so we prostatic, membranous, and the spongy part. So location, prostate part. So you can write the diagram. In this diagram, you can actually make a tabular column where you can, instead of repeating the same thing again and again, the same sentences, you can avoid sentence writing and make a tabular column and write the answer this way. So we have the prostatic part, we have the membranous part here, and we have the spongy part. So the prostatic part is located within the prostate gland, whereas the membranous part is located within the urogenital. So this thing is the urogenital diaphragm, and spongy part is located within the penis. The length of the prostatic part is about 3 centimeters. Membranous part is about 1.5 to 2 centimeters. Spongy part is about 15 centimeters. The shape I already said, this is prostatic part is about, this is the crescent shape or horseshoe shape, you can say. Membranous part is star shaped, whereas the spongy part, in the bulb it is trapezoid, in the body it will be transverse slit. Okay, at the glans, it's not mentioned here, the glans it will be inverted T-shaped, and at the external urethral orifice it will show vertical slit. The diameter here, it is widest, okay, and it is most dilatable here. The membranous part is least dilatable and it is very narrow, okay, whereas the spongy part, okay, this will have a uniform diameter with medium dilatation. Openings. So openings, what we see in the prostatic urethra, we see prostatic utricle opening, the ejaculatory duct which opens there, and the prostatic ducts which open there. Then here in the membranous part, we see minute mucous glands, whereas in the spongy part, we see the openings of urethral glands, or which are otherwise called as Ritter's glands. So these are the features of different parts of male urethra. So here we have the internal urethral sphincter here and the external urethral sphincter outside. So you should know the differences between those two sphincters. So this surrounds the internal urethral orifice, whereas this surrounds the membranous part of urethra. So this is derived from the bladder musculature of the trigonal region, whereas external urethral sphincter is derived from the sphincter urethrae muscle. This is innervated by the sympathetic fibers, whereas this is innervated by the somatic fibers. This is involuntary, this is voluntary. Okay, so those are the differences. So clinical aspects. So clinical aspects, here you can see there is the rupture of the bulbous. So here this is the bulbous urethra. Okay, of the bulbous part of the spongy urethra. No? So this rupture can lead to extravasation of the urine. Okay, so you get extravasated. So it will spread up to here. Okay, because this the fascia, okay, the superficial fascia of the anterior abdominal wall, that is Kapa's fascia, will continue downwards, right? So there is a communication here. Okay, so it will extravasate into this region. Okay. So, and rupture of this, so this is in the bulbous urethra part, but if there is rupture above the urogenital diaphragm, it will lead to deep extravasation. Okay, so here you can see it will be outside the peritoneum or here inside here. Okay, so this is the that is between the superficial layer, superficial fascia and the musculature. Here between the muscles and the peritoneal covering will be the extravasation. So the site will differ. Then based on the opening, where the urethra opens, okay, we have different kinds of hypospadiasis. Hypospadiasis is basically where the urethral opening, okay. So usually this part of the penis, we call it as the ventral part, and the upper portion, we call it as the dorsal part. So usually it should open near the penile part, here at the tip, the urethra. Instead, sometimes it opens on this ventral surface at different positions, and that is known as hypospadiasis. So here, if it opens in the glans, glandular, near the corona, okay, where the glans part, where the skin is present here, okay, the sulcus is present. So that is known as the balanic coronal. Then in the penile part, that is anywhere in the penis, we call it as the penile, then penoscrotal or perineal. So these are the different places where the urethra can open. And that condition is known as hypospadiasis. So that was in the ventral. So sometimes what happens is it opens up in the ventral portion, this thing, dorsal part. Okay, instead of the ventral part or at the tip, if it opens up, it is known as epispadiasis. Okay, so hypo is below, epi is above. Okay, but anatomically, when we talk, this is the ventral surface, this will be the dorsal surface. So we can see here. Okay, so the penis is very short and it has opened up here. Okay. Phimosis. Phimosis basically it is the foreskin. Okay, so foreskin here, if it is very tight and cannot be retracted back, it is called as phimosis. So usually that leads to urinary infections. So usually the mother is taught to retract it. If it can be retracted and clean the area. If not, surgery is done, that is circumcision is done. Okay, otherwise the child will have repeated urinary tract infections. So these are the things which we should know about the male urethra. So male urethra basically that it forms a common passage for both urine and semen. Okay, so male urethra. So you have to know the length of it, the different parts of it, and their features, which I said you can answer in the form of a tabular column. And then you talk about its sectional shapes of the different parts. Okay. And then you talk about the sphincters and the clinical aspects. Okay, so next we move on to uterus. So uterus, you have to know the location of the what is uterus, location, parts and position, ligaments and supports are very important. Blood supply is important. Lymphatic drainage is very important. Okay, a little bit about this development and applied aspects. So the uterus, if you see the uterus, otherwise called as the womb, isn't it? So it is a thick-walled, hollow muscular organ. Okay, so it is primarily concerned with what? Embedding, that is for the implantation of the fertilized ovum and retaining the products of conceptions up to the delivery. That is it retains that so that the fetus can grow. Okay, so that is why it is important, providing the nutrition for that. So this is located. So where is it located? It is located in the lesser pelvis, okay, or the true pelvis. It is located there between the bladder and the rectum. So subdivisions of the uterus. So uterus is subdivided into three parts from above downwards. So if we have the fundus part, the body and the cervix. Okay, so fundus, body and the cervix. So fundus is the part of the body which lies above the, see, this is the entrance of the uterine tube. So the part of the uterus which is above the entrance of this uterine tube is known as the fundus. The body will extend from the fundus to the constriction known as the isthmus. Okay, so here we have the isthmus. So up to this isthmus is the body, and this isthmus is otherwise also called as the internal os. Where the isthmus is, there we have the internal os of the cervix. Okay, cervical canal. Cervix lies below the isthmus and is subdivided by this vaginal wall. Okay, subdivided by the vaginal wall into supravaginal part and a vaginal part. Okay, so this portion will be the vaginal portion of the cervix. This will be the supravaginal portion of the cervix. So measurement, how long it measures. Okay, so the total length is about 7.5 centimeters long. Okay, it is about 7.5 centimeters long. Breadth is about 5 centimeters and thickness is about 2.5 centimeters and it measures about 30 to 40 grams in weight. So near the fundus, there are three attachments here. okay, at the superior lateral angle of the uterus, which is otherwise called as the corner of the uterus. So we have the fallopian tube, the ligament of the ovary, okay, and the round ligament of the uterus. So three structures are attached near the fundus. So this is asked as an MCQ question, okay, or a 3-mark question. Position of the uterus is very important. So normally the uterus is anteverted and anteflexed. So we should know what do we mean by the anteversion and anteflexion. So anteversion is the forward angulation of the uterus. So basically it is the axis between, if you see here, between the cervix and the vagina. Okay, so this measures about 90 degrees. So anteversion is the angle between the cervix and the vagina. Okay, and anteversion. So this was the anteversion. Sorry, anteversion is the angle between the cervix and the vagina. When we say anteflexion, it is the forward angle between the body and the cervix. Okay, this is the body and this is the cervix. So between that angle we call it as the anteflexion angle. So anteflexion, it measures about 125 degree. Okay, 125 on the outside, or up to 170 they say in certain books. Okay, so we can say safely 125. So this anteversion, this angulation is maintained by the forward pull of the uterine fundus by the traction. So here we have the attachment of the round ligament, right? So the forward full pull of that will maintain. The intrinsic growth of the uterine musculature will also maintain, as well as the backward pull by the uterosacral ligament. So both will hold it and keep it in a fixed position there. Okay, so this is how here. So if you see here the peritoneal relation of the uterus, okay, so this is the peritoneum. So it reflects onto the rectum here. Okay, then it reflects onto the uterus. So it covers a little portion of this vagina, as well as that is the posterior fornix here of the vagina. Then we have the body, okay, superior surface of the uterus, as well as the fundus, and then it reflects onto the bladder. So this pouch, okay, so which is formed, the peritoneal pouch, which is formed between the rectum and the uterus, we call it as the recto-uterine pouch, or the pouch of Douglas, okay. So it is a very important pouch which we see there, because it is the most dependent part. Okay, it is the most dependent part of the uterus. Sorry, here, most dependent part in the female pelvis. Okay, most dependent part of the female pelvis. So this I already told you, the parts of the uterus. So shape of the external os. Okay, so it will be more circular in nulliparous female, but once they give birth, okay, so it becomes transverse. Okay, the external os. So coming to the ligaments and structures there. Okay, so we have the structures within the broad ligament of the uterus. Okay, so there are this uterus will have true ligaments and false ligaments. Okay, so true ligaments, what we mean is which are actually providing the support and form ligamental support there. So here, okay, you can remember just a mnemonic to remember the names. That's it. Okay, so R stands for these are all the true ligaments. Okay, so these belong to the true ligaments of the uterus. So what are those? R is for round ligament of the uterus. U is for uterosacral ligaments. M is for McInrod's ligaments or transverse ligament. And pub is pubocervical ligament. Okay, so round ligament, uterosacral ligament, McInrod's ligament, and pubocervical ligament. So these ligaments, they form the true ligaments. Whereas false ligaments are formed by the peritoneal folds. Okay, we have utrovesical fold, rectovaginal fold, and pair of rectouterine folds, okay, and broad ligament. So broad ligament, what we are seeing here, it is actually a peritoneal fold, okay. So here, this is the rectouterine fold, okay, that is the pouch of Douglas belongs to the rectouterine fold. So this rectouterine pouch, it is the most dependent part of the pelvic that is the pelvis in the females. So boundaries, if you see, it is in the front, it is the supravaginal part of the cervix, okay, and the posterior fornix of the vagina. Behind will be the middle 1/3 of the rectum, and on each side it will be the rectouterine fold. So this bottom or the here, okay, it lies about 5.5 centimeters above the anus. Okay, so from the anus, it is about 5.5 centimeters and 7.5 centimeters from the vagina. Okay, external orifice of the vagina. So from here to here, it is 7.5 centimeters. Year to year, it is 5.5 centimeters. So usually there is collection of pus of blood. So whenever there is any infection or anything, the pus of blood is mainly collected in this part because it is the most dependent part. And we can make an incision, okay, through the posterior fornix of the vagina and reach there. That is known as posterior colpotomy. Without opening the anterior abdominal wall, we can reach there and remove the pus. Okay, so here structures within the broad ligament is commonly asked as a 3-mark question or an MCQ question. Okay, so here what you have to know is what the structures which we present here. So basically this round ligament, okay, we see, here this entire thing is the broad ligament. So we see the round ligament, okay. We see part of the ureter, the uterine artery. These are paraoophoron and epophoron, okay, the Gartner's duct. We see the ovary, okay, the ovary, the round ligament of the ovary, we see here. This is the ovary, okay, the ovarian fimbriae, the vesicular appendix, ovarian artery. So these are the structures which we see within the broad ligament. Okay, so this is like in a section wise, we can see this. Okay, we are seeing the fallopian tube, the round ligament, the ligament of the ovary, the uterine artery. Okay, in the sectional view, you are able to see. Arterial supply of the uterus is important. So arterial supply of the uterus is mainly by the uterine artery. Okay, so uterine artery supplies the uterus. So here, okay, how it supplies is important when you have to, because this is asked, that is mainly known as the intrinsic circulation of the uterus. So the artery here, when we see here, so the uterus is mainly supplied by the uterine artery and partly by the ovarian artery. Okay, partly by the ovarian artery here, the ovarian artery, and mainly by the uterine artery. So this uterine artery, it is a branch of the anterior division of internal iliac artery. And if you see this uterine artery, it crosses, okay, so if you see above, it will be crossing in front of the ureter from lateral to medial side. Okay, so this is the ureter. It crosses from the lateral to medial side. And then it runs upwards along the broad ligament, along the lateral border of the uterus. So close to the area of the crossing, okay, so where it crosses, it will give branches. Okay, so one is it will give a uterine branch, it will give a ureteric branch, okay, a vaginal branch, and a cervical branch. So a cervical branch, a ureteric branch, and a vaginal branch it gives. Okay, so then if you take a section and see here, as the uterine artery ascends, okay, as it goes up, it will give here, these are known as the coronary or arcuate branches. Okay, so it will giving these branches all around. That is on the anterior surface as well as on the posterior surface it gives, and it anastomoses with the branches of the opposite side. So from both the sides, on the anterior surface as well as the posterior surface, it gives these branches, and these branches are known as the arcuate arteries. Okay, so from this arcuate or the coronary arteries, now if you see, okay, so this is a section. So if you take as the anterior surface and the posterior surface, so the uterine artery has given these arcuate arteries, okay, both surface, and they are anastomosing with each other. And from these arcuate arteries begins the radial arteries. Okay, radial arteries will begin. So radial arteries, they will now this, see, if in the uterus we have 3 layers here. Okay, we have the innermost, that is the endometrial layer, then the myometrial layer, and the perimetrial layer, right? So accordingly, these will form plexus in the different layers. Now here, okay, so these radial arteries will arise and they pierce the myometrium. Okay, they will pierce through the myometrium and they form what we call it as the stratum vascular. Okay, so this is the stratum vascular piercing through this myometrium we can see. Okay, this outside covering will be the perimetrium. So this layer, brown is layer, what you are seeing is the myometrium. So here all these radial arteries will anastomose, they form what we call it as the stratum, or stratum means a layer, stratum vascular layer. So from the stratum vascular layer, what happens is 2 sets of arteries will begin. So one is longer, if you see, one is longer, one is shorter. Now endometrium is divided into 2 parts, isn't it? One is called as the functional layer, another one is called as the basal layer. So this basal arteries, they supply the basal zone, whereas the this longer, that is the spiral arteries. Okay, so it gives 2 branches. This is the basal and spiral arteries. Spiral arteries, they reach up to the functional zone of the endometrium. So that is the blood supply, intrinsic circulation of the uterus. That is very commonly asked, intrinsic circulation. Then coming to the lymphatic drainage. So the lymph vessels which drain the uterus, they form submucous, intramuscular, and subserous plexus. Okay, so from 3 areas they drain. So from the fundus here, from the fundus and upper part of the body, the lymph is drained into pre-aortic. Okay, so from here it goes up to the pre-aortic and the lateral aortic group of lymph nodes. Okay, and some few may also go into the superficial. From this area, it may also go into the superficial inguinal group of lymph nodes. Whereas the lower part of the body, most of the lymphatics, they drain into the external ilia group of lymph nodes. Then from the cervix, some laterally, they pass through the parametrial tissue, that is around the uterus, that tissue it will pass in the pelvis. Okay, and then it will drain into the external ilia group of lymph nodes as well as to the obturator group of lymph nodes. Whereas posteriorly, it will pass along the lateral pelvic wall and it will drain into the internal ilia group of lymph nodes. Okay, and posteriorly, they will go to the sacral group of lymph nodes. Okay, so that is the lymphatic drainage. Next important is the supports of the uterus. Okay, so supports of the uterus, they include many interdependent factors. Okay, so why these supports is they prevent the prolapse of the uterus or the downward displacement of the uterus through the vagina. Okay, so these functional supports are provided by the muscles, by the ligaments, by the viscera around there, and whatever the connective tissue which is present in that region. So the muscular support is mainly provided by the levator ani muscle. Okay, so the levator ani muscle of the pelvic diaphragm, it provides the muscular support as well as the puborectal sling. Okay, so from the pubic to the rectum, there will be a puborectal sling formed by this levator ani muscle. So it will prevent the prolapse of the uterus. The other structure which will help will be the perineal body. Okay, so perineal body will be present down here. So that will also provide the support. So usually during delivery, during episiotomy tear and all, we give an episiotomy to prevent the perineal tear. Okay, so the perineal body tear. So this perineal, then the ligamentum support is provided by the McEnroth's ligament. okay, which is otherwise called as the transverse ligaments. Okay, the round ligament here. Okay, sorry, here. So this is the then pubocervical ligament as well as the uterocervical ligament, transverse ligament, and the round ligament. They provide the support. The visceral support is provided by the posterior wall. Okay, the visceral, this is the posterior wall of the vagina, which is directed downwards. So this will provide the support, and as well as the upper surface, because this portion, uterus, lies over the superior surface of the bladder. So they will provide the support. Okay, so these are the things. So when the supports are loose, what happens? It can cause the prolapse. So in the uterus, what the main things which you need to remember or know about is the parts which can be asked as a spotter question. Okay, parts of the uterus. You have to talk about the position of the uterus. And you have to talk about the true and the false ligaments. Also, pouch of Douglas. When you talk about ligaments, pouch of Douglas is important, which can be individually asked as a 3-mark question or as an MCQ question. The boundaries can be asked. And even in spotters for practical exam, that area is marked and asked. Then supports of the uterus, blood supply, and lymphatic drainage. So that is very important, which you have to know. So next we move to descent of the testis. So short answers, descent of the testis. So here, what do we mean by descent of the testis? What is the course of descent, factors responsible, and what happens if the descent doesn't occur normally are the things which we need to know. So the testis, basically, it develops retroperitoneally in the dorsal, that is the posterior abdominal wall, it is developed. And it is attached to the medial side of the mesonephric ridge. Okay, so now here, so see, this is the posterior abdominal wall. So here we have the urogenital ridge, which will divide into nephrogenic cord and a genital ridge. So this genital ridge is the one which forms the gonads. Okay. So from this, in the males, this genital ridge forms the testis. So it is developed in the retroperitoneum, the posterior abdominal wall. Okay. So the lower end of this, so if you see here, testis, the lower end of it, it will be attached to the base of the scrotum by a structure, what we call it as the gubernaculum testis. So, yeah. So proximally, this gubernaculum testis will be attached to 3 structures. That is, one is to the lower pole of the testis, to the peritoneum in front of the testis, as well as to the mesonephric duct, which will be passing behind. Okay, this is the mesonephric duct. So it will be attached to the mesonephric duct. So 3 things it will be attached to the peritoneum in front, to the lower pole of the testis, as well as to the mesonephric duct. This gubernaculum testis will be attached. Whereas distally, the gubernaculum will split, okay, here. So distally, the gubernaculum will, mainly it will be attached to the base of the bladder, and it will also split into many fibrous thread-like structures, which is known as the tail of Lockwood, okay, tail of Lockwood, and it can be attached to the different structures, okay. So one, as normal, the bottom of the scrotum, to the perineal region, to the symphysis pubis above the penis, to the saphenous opening, and also anterior superior iliac spine. So those are the other regions, okay, where it can be attached. Okay, so to the bottom of the one is, it can be attached to the scrotum. Okay, so to the bottom of the scrotum, which is normal, or it can be attached to the perineum. Okay, it can be attached to the perineum. and it can be attached to the, or it can be attached to the symphysis pubis. Okay, symphysis pubis, saphenous opening. Okay, saphenous opening, or it can be attached to the anterior superior iliac spine. Okay, saphenous opening in the thigh region. So all these regions, it can be attached. So as the development progresses, okay, so what happens is this gubernaculum shortens. It shortens and it will pull the testis downwards. Okay, so along as it pulls it downwards, it will, because it is attached here to the peritoneum, it will pull the portion of the peritoneum also. And that portion is known as the processus vaginalis. So into these processus vaginalis, the testis will project, okay, from behind. So since this gubernaculum is attached to this, as well as to the mesonephric duct also behind, even that portion comes down. So during its course of descent, what happens is, during the 4th month of life, 4th month of fetal life, okay, fetal life, the testis will first come down to the iliac fossa, okay, the right and left iliac fossa, the right kidney and left kidney comes. And at the 7th month, it will reach the superficial, the deep inguinal ring. Okay. 8th month, it will travel through the inguinal canal. And 9th month, it will come to lie near the superficial inguinal ring. Okay. And after birth, it will reach its normal position, that is the scrotum. And this descent is important basically to maintain the temperature for normal spermatogenesis. Okay. So what are the factors which are responsible? One is this the main factor is this gubernaculum testis. Second is the intra-abdominal pressure. Okay, that will also help in the rapid descent. Then the temperature. So ideal temperature should be about 4 degrees less than the abdominal temperature, which the scrotum provides, and that is why it is descends down. And next, the arch fibers. In the inguinal canal, we have the arch fibers of the internal oblique, which are forming the roof of it, right? So that squeezes also, and that will also cause the descent. Then the fetal curves. The fetus, as it is growing, the curvature, as it is moving, the curvature changes, okay? So uncurling of the fetal curves, as well as the hormone secreted by the fetal testis, okay, which will, from the interstitial cells, they secrete a hormone which will help in the descent of the testis. Okay, so those are the factors responsible. So what do we mean by cryptorchism? Cryptorchism is basically when the testes do not descend. Okay, undescended testes. Cryptorchism is otherwise known as the undescended testes. Okay, so when the testes do not descend to the scrotum, we call them as cryptorchism. So this is, if it is left without treatment, it can undergo malignant change because the temperature is different, and testis may undergo malignant changes. Cryptorchism, when we say both the testes, the right and left testes will not descend. Okay. Excuse me. Monorchism, when we say the only one testis is intra-abdominal, other would have descended in the normal position. Then we have partially descended testis. So testis may be arrested anywhere. So actually I told you, so first it will lie in the iliac fossa, then comes to the deep inguinal ring. At 7th month, 8th month traverses through the canal, and by 9th month it will be near the superficial ring, and at birth it will descend to the scrotum. Next is ectopia testis. Okay, another condition is ectopia testis. Ectopia testis, here the testis can be in an abnormal position. Okay, so I told you, so this gubernaculum in the lower part, like by 2 tails of Lockwood, it is attached to different parts like the perineum and symphysis pubis just above the penis here, in the perineum near the saphenous opening, or near the anterior superior iliac spine. So when the testis is present there, okay, we call it as the ectopic testis. So this is, it deviates from its normal path of descent. Okay, and because of that, if the processes, and during this descent, after its descent to the scrotum, what happens is the processus vaginalis, okay, which we see here, this processus vaginalis here, Okay, this is the peritoneal cavity. So this is the processus vaginalis, right? So it will actually, after the testis descends, it will obliterate. Okay, and it forms the tunica vaginalis. So sometimes it doesn't obliterate and it remains patent. So when it remains patent, what happens is the fluid from the peritoneal cavity can get collected around the testis and in the scrotal region, which we call it as the hydrocele. So these are the common conditions associated with the abnormalities associated with the descent of the testis. Okay. So descent, when you write about descent of the testis, you have to know why it is important, why the testis descends. Okay, then you have to talk about the normal development, where it happens, where it is normally developed, the course of descent, okay, and the factors. Basically, about the gubernaculum testis, okay, gubernaculum testis, and the other factors you should mention. And you should also mention about the gubernaculum testis above and below where it is attached, okay, and the tails of Lockwood, you have to, because that is important to explain the anomalies. So later you write about the different types of anomalies, okay, right. So next we move on to the next question, that is the tracheoesophageal fistula. So tracheoesophageal fistula, what is this? Okay, so tracheoesophageal fistula, as the name says, it is an abnormal communication between the trachea and the esophagus. So this anomaly is usually associated with whenever there is an esophageal atresia, that when the esophagus doesn't develop properly and it leads in atresia, it results in tracheoesophageal fistula. So it occurs in about 1 in 3,000 to 4,000 live births. So why is this defect? Okay, this defect is basically to the defective development of the tracheoesophageal fistula. So usually between this trachea develops as a diverticulum, okay, from the foregut, which later forms the esophagus down here, right? So this, between the developing esophagus and the developing trachea, a septum develops here and it will separate once the development progresses. Okay, so but if this tracheoesophageal septum doesn't form properly or there is a defective development of that, it results in this condition. Okay, so the different types are the upper part of the esophagus. So one is the upper part may result in a blind pouch and the lower part may communicate with the trachea. So this we see in about 85 to 90% of the population of the newborns with this condition. Okay, this is common type. Then here, if you see, the distal part will not communicate. Instead, it communicates it will be attached like a fibrous cord. Third type here, both the proximal part as well as the distal part will form a narrow canal and it will communicate with the trachea. And the other condition, the proximal part will connect, whereas the distal part will remain atretic. Okay. And the fifth type, where we see both separate communications, we see. Okay. The upper part and the lower part. So these are the different types of tracheoesophageal fistula. So whenever you write about abnormal condition, okay, or embryological developmental defect, always you should write first what is the defect, okay, and what is the anomaly, okay, what is the cause for that anomaly, rather than mentioning its cause of the anomaly, rather than mentioning its signs and symptoms, okay, which you can write later. The main important here in anatomy and as an embryology part of it, we want what happened. Okay, so in tracheoesophageal fistula, the main cause will be the defective development of the septum, okay, of the tracheoesophageal septum. Okay, tracheoesophageal septum will not form properly. Okay. The next question is rotation of the midgut. Okay, so rotation of the midgut, when we say, so here, what are the things happening, okay, in the rotation of the midgut? So the midgut here, see, basically what happens is during the development of different organs, there is no enough space for the development of the intestinal loop, okay? So for that purpose, this midgut part, which basically forms the lower part of the duodenum, the jejunum, the ileum, and the colon up to the transverse two-thirds of the transverse two-thirds of the colon, okay? Two-thirds of the transverse colon. So all these parts, they are derived from the midgut. So since that is a big loop of intestines and there is no enough space, okay, it develops outside the fetus, okay, develops out there, and then later it is taken within. So when it is taken within, it undergoes rotation to occupy the normal position, okay. So this is what is about rotation of midgut. So initially, this midgut is attached, okay, to the umbilicus, that is the yolk sac, primitive yolk sac through the umbilicus, umbilical opening. This is the umbilical coelom or the umbilical opening, we say, okay, by a duct. This is known as the vitellointestinal duct. So through the vitellointestinal duct, it will be connected to the yolk sac, that is the tertiary yolk sac, okay. So it forms a loop. So this loop will be attached from posteriorly. It will be supplied by this superior mesenteric. Okay, this is the superior mesenteric artery. So superior mesenteric artery to the dorsal mesentery, it will be attached. So this portion above, when it forms a U-shaped loop, the portion above, we call it as the pre-arterial segment, and this portion we call it as the post-arterial segment. Okay, so first, so the pre-arterial segment basically forms the distal half of the duodenum, the jejunum, ileum, okay, is formed. Whereas the post-arterial segment will form the terminal part of the ileum, the cecum, the appendix, the ascending colon, the transverse colon, okay, two-thirds of the transverse, proximal two-thirds of the transverse colon. So once in the first stage of rotation, what happens? Once it forms the loop, so above is the pre-arterial, below is the post-arterial. So here it comes out and it undergoes first rotation, okay, anti-clockwise, it rotates 90 degrees. So the pre-arterial segment will come to lie on the right side and post-arterial will be on the left side, okay. And this, at the junction of that pre-arterial, post-arterial part, it will give a bud that is known as the cecal bud. Cecal bud is given. Now here, it undergoes development. Meanwhile, in the abdominal cavity, the other organs will be developing, okay. So at this point, this segments, that is the pre-arterial and post-arterial segments, they undergo formation of the loop. So when they form the loop, okay, so what happens is, that is happening where? Outside the cavity, that is in the outside the umbilicus, okay, outside the umbilicus within, okay. So this is known as the physiological umbilical hernia, okay, physiological umbilical hernia. So this remains from the 6th week up to the 10th week in that stage. So after 10th week, okay, by that time the liver would have ascended up and occupied, it's not like the liver would have been developed, okay, the kidney would have ascended, okay, the testes would have been coming down. So all these things would have been happening. So testes or the ovaries, the gonads basically. Okay, so all these things and the space would have been created. So because of that, what happens is this intestinal loop is taken inside. Okay, now to go inside, when it came out, it was just a U-shaped loop and the umbilical opening was big. Okay, but by now, what has happened is the umbilical opening has narrowed because of the development of all the walls, body walls, and approximation there. And on the outside, these loops also have increased. The entire pre-arterial segment has formed all the loops, except the post-arterial segment will remain just like that. But pre-arterial, it would have formed all the segments, that is the duodenum, jejunum, ileum, everything, okay, up to ileum. So now it at once it cannot go inside. So because of that, only the pre-arterial segment first goes. So when it goes, it will go behind the superior mesenteric artery. Okay, and it will go to the left side. So instead of going to the right, it goes to the left. Okay, then after that, this segment goes. So once that goes here, okay, what happens? It goes to the next stage of rotation. Okay, so from here it ascends up. Okay, so this arrow mark, it is showing upward. So it will be undergoing continued rotation. So after one, it once appears here. Now it has to go to the opposite side, right? Because the entire segment has come here. Okay, so from here, it again undergoes 190-degree rotation upwards, and then again 190-degree rotation right. Okay, and the cecal bud, which had come down here, would have moved up here 190, here 90, and complete 270-degree of rotation. Okay, and comes to lie below the liver. So that is known as the subhepatic position. Okay, so once it comes below that, okay, see here, if you notice, the cecum is there. Okay, this will be the terminal part of the ileum, right? This would have actually come here when it has come inside from the umbilical hernia part. When it comes inside, it would have gone here. So that is why it undergoes rotation again. Now it has come here. So this junction is where cecal bud is, and the terminal ileum part is. Now the portion, that is the cecum, has to develop, the ascending colon has to develop. So what happens is, from this position, the cecum will start growing downwards. Okay, so as it grows downwards, that portion, okay, from the subhepatic position up to the iliac fossa becomes the ascending colon, and this portion will be the cecum. And to the tip of, that is apex, will be the appendix, which will be attached there. Okay, so usually initially the apex, near the apex, the appendix would be positioned. Okay, later on, after birth, it occupies the, now it comes to the normal position with the further development of the cecum. So here, what are the congenital anomalies which we see? Okay, so usually I said the loop is attached outside, okay, to the vitellointestinal duct, to the tertiary yolk sac. So once it descends that vitellointestinal duct, it obliterates. But if it doesn't obliterate, it remains as a sinus. Okay, if it is completely patent, it forms a fistula. Okay, and if the distal end and the proximal end obliterates, and it remains as a cyst. Okay, some of the congenital anomalies. This is the congenital umbilical hernia. Okay, sometimes this portion here, the anterior abdominal wall, is not formed. The mucosa is shown outside. Okay, small portion, and that, since it gives it will be very mucosa, very vascular there. Okay, it gives the appearance of a raspberry. It is known as raspberry tumor. Here, the anterior abdominal wall is not formed, and the entire intestines is exposed outside. Okay, this one just covered by the amniotic membrane. So this is known as exomphalus. Okay, so here it remains outside itself. Okay, the physiological umbilical hernia completely remains outside. That is known as exomphalus. Here, the anterior abdominal wall is not formed, and the entire loop is lying outside. Okay, so this is known as gastroschisis. Then other things which we see is undescended cecum and appendix, where the cecum and appendix does not descend down. Okay, and others are non-rotation, where the rotation doesn't happen, or it can undergo malrotation. Okay, on the other side. So those are the abnormalities which we see in the rotation of the midgut loop. Then coming to the last question, that is development of pancreas. Okay, so pancreas, as we know, has got the uncinate process, the head, the neck, the body, and the tail. Okay, so these parts are derived from two different sources. So here in the foregut part, okay, where the first and the upper portion of the duodenum is developing, okay, second part of the duodenum is developing. In that region, there will be two buds which will be formed. Okay, one is the ventral bud, another one is the dorsal bud. So on the anterior border, we have initially the loop is straight. Okay, so that will have an anterior border, posterior border. Along the anterior border will be the ventral bud, and along the posterior border will be the dorsal pancreatic bud. Okay, so this ventral pancreatic bud will be in relation to the developing hepatic bud. Okay, where the liver and the gallbladder will be developing. So as the liver develops, as it occupies its normal position on the right side, that is the right hypochondriac region, what happens is this portion, which is forming the duodenum, that also rotates. Okay. So because of the rotation, this ventral bud comes to lie on the dorsal side and it fuses with the dorsal bud. Now, each of this will be having their own ducts, which will be opening into this duodenum. Okay. So, here, when after these fuse, this ventral bud, it will form the uncinate process and the lower part of the head. Whereas this portion, that is the dorsal bud, forms the upper part of the head, the body and the tail. Now, next will be the pancreatic duct. So if you see here, initially they are opening separately. Okay. So now once both the buds, the ventral and the dorsal bud fuse, what happens is, okay, there will be a communication between the duct of the dorsal bud, ventral bud, and the duct of the ventral bud. Okay. So this portion, that is the distal portion of the duct of the dorsal bud, the communicating part, as well as the proximal portion of the duct of the ventral bud. Together, they form the major pancreatic duct, which we call it as the duct of Wirsum. This portion, the proximal portion, it remains as the duct of, that is minor pancreatic duct or duct of Santorini. So to this major pancreatic duct, the bile duct will come and open, and both they join together and they open into the duodenum as the ampulla of Vater. Okay, so this is what happens. So this will be the ventral bud, dorsal bud. So with the rotation of the duodenum, this ventral bud moves towards the dorsal and it gets fused. Okay, so with this rotation, this portion becomes retroperitoneal here. So sometimes what happens, this ventral bud may form two divisions. It may be formed. These are all the anomalies, annular pancreas. Okay, so it can form a bifid. Okay, it may divide the ventral bud and it will encircle around the developing duodenum. So because of that, what happens is it will encircle and then it will fuse with that. So because of that, this portion of the duodenum is narrowed down and that is known as duodenal atresia. And this pancreas, we call it as the annular pancreas. This is a divided pancreas where the buds don't fuse at all and they separately open into the second part of the duodenum. And there may be accessory pancreatic, ectopic pancreatic tissue, which may see in the ileum or around the umbilicus, in the omentum, near the spleen or near the Meckel's diverticulum, we may find the accessory or ectopic pancreatic tissue. This is inversion of pancreatic duct. So here what happens is this duct, okay, so instead of joining here, communication being established, the main pancreatic duct is directly formed by the dorsal itself, dorsal pancreatic bud, okay, and this will remain as the minor pancreatic, and the bile duct will join the minor pancreatic duct and open into the major duodenal papillae. So these are some of the anomalies. So here, when you write the answer, you have to write about mainly the source. Okay, so source will be the ventral and dorsal bud. Ventral and dorsal bud. Okay, and then you talk about, so ventral bud, what are the structures formed, and dorsal bud, what are the structures formed, you need to write. Then you have to write the steps of development, like the rotation and fusion. Okay, and then you have to also complete it with writing about the development of ducts. Okay, development of the ducts. Then later mention about the anomalies. Okay, so anomalies, mainly annular pancreas is very important. Okay, annular pancreas, it is the common developmental anomaly we see. Okay, so those are the things you need to write in embryology about development of the pancreas. So with this, we finish today's class. So thanks for watching. For more content, you can follow our social media handles on YouTube, Instagram, Facebook, as well as Telegram. You can download the app, which you get on Google Play as well as App Store. So until next time, thank you.